So now we're going to get to the main part, which is part 2, and that's actually treating anaphylaxis. Treating anaphylaxis is a core specialist emergency medicine skill. This is just like we expect surgeons to be good at operations and not cut the wrong thing while they're doing the operation. We expect emergency specialists to be experts at resuscitating someone with anaphylaxis. I'm going to show you a video of James Sindos when he was 16, and I just want to show you how good he is at playing the piano. Here we go. James died from anaphylaxis, and the reason why I'm showing you that video, he was 16 when he played that. He died when he was 17. And the reason I'm showing you that video is because anaphylaxis happens in young, healthy, otherwise healthy people. Yes, he might have some past history of asthma, but he's otherwise well. He's got another 80 years to live. And what we're talking about today is high yield in terms of interventions to save somebody's life and let them live happily and healthily. So that was James, incredible piano player. If you get through someone through anaphylaxis, he'd be happily playing the piano again. But unfortunately, he died. And I'll show you what happened to James, actually. This is James's family. Harry and Vanetta, his parents. I spend a lot of time now with these guys. He's got 3 older sisters. They're all beautiful. And they miss James dearly. That's on their trip to Greece. They're just another family in Melbourne living with a tragedy. So this is what happened to James. So he was 17 years old. He was allergic to cashews. He just finished the school play, Mamma Mia. He's in year 12. He's about to finish school. He ordered a sandwich from a vegan restaurant that had cheese sauce. Now, cheese sauce in a vegan restaurant means cashews. But as a teenager, you don't know that. It said cheese sauce. In the fine print, it said something about cashews, but he ordered it, he ate some, and he developed acute allergy. At the beginning, it was mild. He had some skin symptoms, some tummy, some abdominal pain, felt a bit itchy in the throat. They called the paramedics. The paramedics gave him 2 doses of IM adrenaline, but he didn't actually really meet the criteria for anaphylaxis in that sort of more severe, acute allergy spectrum. But as he was being triaged at a metropolitan Melbourne emergency department, he became wheezy. And the paramedics alerted the triage staff and the bedside nurse to the fact that there were some new symptoms, but he got put in a single room. And by the time he gets to the single room and he's being triaged, he's got 19 minutes left to live. The first thing that they do is, because James is trying to use his puffer, is to get him a spacer and give him Ventolin. So it takes some time to find the spacer, but they put an IV cannula in. That's great, but he doesn't get any IM adrenaline really until 4 minutes before he arrests. There's some time that goes past. During that time, he starts to get more and more short of breath, and he actually starts asking for help. He says, I can't breathe, I'm going to die, and says that multiple times. And medical staff around him say, James, your breathing looks fine to me. 4 minutes before he stops breathing, he gets IM adrenaline. Now, this is my question to you. How long does it take? I want you to think in your brain, how long does it take IM adrenaline to get to peak effect? Just have a think of a number. What do you think? The answer is 5 to 8 minutes in the literature. So you're not going to get peak effect until 5 minutes, and James has only got 4 minutes left. So that's going to be important when we talk about how we respond to people in extremis, understanding the time frames. If you give subcutaneous adrenaline, which we stopped doing a long time ago, it takes up to 20 minutes to get maximum effect. So if you accidentally give it subcut and it's not intramuscular, then you actually might not be getting any adrenaline for some time. So you've got to keep in mind that, maybe, if you're not getting an effect, was it subcut? Is it just because, that there's some other risk factors like high dose allergen, or there's some concurrent viral illness or pre-existing asthma, something's going to make them have a severe reaction. But if you're not getting a reaction, you need to if you're not getting improvement, you need to keep going. All right, so James then stops breathing in his cubicle. He gets moved to resus. He sort of crashes, the hypoxic agitation, and there's a loud bang, and they start CPR in the cubicle. They move him to resus. They start bag valve masking him. They say that feels funny, so they put a laryngeal mask in. That feels a bit better, but we'll come to why that's probably not right. The LMA was thought to be effective, but it's probably not right. He doesn't get real adrenaline until 13 minutes after he's arrested. And he doesn't get intubated until 17 minutes after he arrests. After he gets intubated, he's difficult to ventilate, high pressures. His heartbeat starts to come back. It looks a bit funny, a bit wide. Somebody decides that needs a shock. They give one shock. They're still having tight ventilation, but then they decide to give some amiodarone for unclear reasons. And I highlight this because this is somebody trying to extrapolate a VF algorithm to a completely inappropriate situation. He gets a dose of amiodarone and immediately becomes asystolic on the end of the push. There was no indication for amiodarone. In fact, it's contraindicated. And then he gets another dose. And he eventually goes on to ECMO, but he becomes brain dead and dies 24 hours later after withdrawal of treatment. So this happened in a metropolitan emergency department in Melbourne. Melbourne's a city of like 4 million people. All right, so we're just going to quickly go through the nuts and bolts of consensus anaphylaxis management. It's pretty similar all over the world, except we're not calling it epinephrine, we're calling it adrenaline. And what we do here is we give 0.5 milligram, so we're just going to talk adult doses, or 10 mics per kilo. We give it every 5 minutes because maximum effect at 5 minutes. If we've still got symptoms, we need some more. So that makes sense. That's why it's every 5 minutes. That's good. If we need more than 2 doses, we start an IV adrenaline infusion. We supplement things. If they've got wheeze, we supplement it with bronchodilators. If they've got low blood pressure, we supplement it with the adrenaline infusion, and sometimes we might need noradrenaline, vasopressin. We're happy to escalate to whatever we need to keep a blood pressure up. We give some fluid boluses. And we might do some nebulized adrenaline for some airway symptoms for what that's worth. But the parenteral adrenaline, the IM adrenaline will be better. All right, so that's what we do. Now, we're going to come to the IV adrenaline bolus in a second, and I've got the adrenaline tachometer up in that corner there. Now, the adrenaline tachometer means that sometimes we just need 1 dose, or some patients, acute allergy, they don't need anything, and they just get observed, go to short stay, go home with the follow-up. Sometimes I need 1 dose, sometimes 2 doses. More than 2 doses, we're getting down to the 10%, and to need IV adrenaline, we're getting down to really small percent. So, it depends which cohort you read in the literature. Arrests are rare, but important. So, this is the nuts and bolts of it. For the wheeze and asthma component of anaphylaxis, we use parenteral adrenaline, IV or IM, plus the bronchodilators, plus in Australia, in Victoria, we would give an IV for anyone with asthma now. We're pretty comfortable with that. And we might intubate them. For the airway component of anaphylaxis, it's the same, parenteral adrenaline, plus maybe some nebulized adrenaline for what that's worth, and an early ETT if it's progressing. And for blood pressure, we give the fluids on top of the parenteral adrenaline, but we always start with adrenaline. Now, IM adrenaline is completely safe. There's 20% of people who might get some minor side effects, tachycardia, some tremor, but to cause any harm from IM adrenaline is exceedingly rare. Feel comfortable giving it, feel comfortable giving multiple doses. We swung away from IV adrenaline years ago because people were giving too much. We know IM adrenaline is extraordinarily safe, but as critical care specialists, you need to know how to do more than IM adrenaline. Yes. If you want to give IV adrenaline because we need help now, not in 5 minutes' time when the IM adrenaline is kicking in, the dose is 1 microgram per kilogram. This is APLS, which is a paediatric resuscitation course that we often do in Australia. It's elsewhere in the world. But I'm just drawing your attention to the middle row, which is adrenaline IV, and that it's got titrate 1 microgram per kilo with a star on it. And I've put the star up the top, and the star says 1 microgram per kilogram given over 1 minute. The range 30 seconds, push, to 10 minutes. And when something says 30 seconds in a book, that means just, push it in. It's a bolus. So if you need help right now, then you need to have the adrenaline IV ampule drawn up in your hands. And I'm going to put a video up of how to draw up IV adrenaline, because it's a core technical skill for doctors to be able to go get an ampule of adrenaline and make it into 1 milligram in 10 mils, or another dilution of 10 for the smaller people. But you need to know how to do it. Take that home with you, 1 microgram per kilogram as an IV bolus if you're in trouble. Remember, the guidelines are always written in stepwise severity. So it starts, this is what you do with mild cases, moderate, severe, but sometimes you're faced with a patient who's got the severe case. They haven't gone through each stage. They just present on your doorstep blue in the parent's arms, or by ambulance with a GCS of 3. And you need to start at the bottom. So that means going for the IV adrenaline first and then supplementing with an infusion. So speaking of adrenaline infusions, how long does it take to get an adrenaline infusion drawn up in your department? What do you reckon? I've done this talk a few times now, and 10 minutes is the consensus. So, 10 minutes, and then you've got to start the pump, and it's got to get rid of the dead space, and you started at a low dose, and then you need to titrate up. It's a slow process. That's great if they're awake and talking. It's completely inappropriate to wait that time if a patient's in extremis and unconscious. Remember that asthma can decompensate very rapidly. It's inversely, the airway resistance is inversely proportionate to the radius to the power of 4. So small changes in the bronchioles will cause catastrophic changes in resistance, and there'll be sudden deterioration. So just like all, especially young people in paediatrics, they compensate in a linear fashion and eventually just suddenly stop breathing. So you need to intervene before that happens. So if there's severe hypoxia or somebody's begging for help, those are signs of impending arrest, and you need to get some push dose IV adrenaline, NIV if you can, and get ready for the next stage. So we're getting close to the end of this section, but I just want to say what should have happened to James as an emergency specialist myself. Hi James, it looks like you've got some asthma symptoms with your anaphylaxis. Don't worry, we're going to look after you. We're going to give you some IM adrenaline, and we're going to give you some Ventolin. We'll give you 12 puffs, and we'll give you 8 puffs of ipratropium as well. And we're going to move you to an area where we can keep a closer eye on you. And then 5 minutes later, because it takes 5 minutes to deliver 12 puffs of salbutamol and the ipratropium, and this is what I did for an anaphylaxis patient at my shop, a couple of months ago. So and it worked really well. 5 minutes later, they're still wheezy, and our endpoint is saying, well, if they're deteriorating, we need to keep escalating. But if things have stabilised, we can just think about our next move and do things slowly. And if they're getting better, we can back off. So we always have to keep thinking about our endpoint. If improving, we can say, okay, all right, well, we'll just see if that IM adrenaline is going to keep working. But if they're deteriorating, you need to keep escalating. So 5 minutes later, he's still wheezy. James, you're still wheezy. In fact, that really doesn't look like it's done anything. Here's another dose of IM adrenaline, and here's another dose of inhaled bronchodilators. James gets worse. Turns out he's got a cold, he's got asthma. He had a decent dose of cashews. This is a catastrophe. James, it looks like your asthma is getting worse. Let's get some IV adrenaline. Nurses, can you get me 1 in 10,000 adrenaline ampule, and I'll draw that up. And James, I'm going to give 100 micrograms. Can you get the intubation equipment ready? We'll get the adrenaline infusion coming. James, you're going to be okay though. We've got this under control. We could try some NIV if we had time to do that, but we would be totally prepared for him to decompensate and stop breathing, about to intubate him. And that's what should have happened to James. He might have been fine after the first dose of adrenaline if you had have got it early enough.